I think what we have seen with Professor Jagannathan's talk is how one of the best surgeons in India can do a good job with white cataract. What I am going to show you is how any surgeon in India can do a good job with white cataract. So that is where the femtosecond laser really plays a role. We are at present fortunate to have two femtosecond laser systems with us. The first being the Lensex with our experience of much more than over 2 years. With a Catalyst we have an experience of about 2 months. So what the femtosecond laser does is it basically does 3 things very well. It makes a capsulorhexis, which is more often than not free floating. It fragments the nucleus and it makes incisions. In cases with astigmatism, which are up to the tune of 1.5 diopters, arcuate incisions with the femtosecond laser are a fairly predictable way of correcting the astigmatism without resorting to toric IOLs. However, when the astigmatism is larger, the toric IOL is a more predictable option. Now, as I said, the key to the success of the femtosecond laser is really the fact that it's beautiful, in the fact that it makes a near perfect rhexis every time. This rhexis can be sized and centered precisely, and this is of course a challenge in complicated cases. Now, this is a patient of a white cataract who's opted for a multifocal IOL. Now, as we have seen, white cataract presents a challenge for capsulorhexis due to the higher intraventricular pressure. In a multifocal lens, you cannot have a very small rhexis, you cannot have a decentered rhexis, so you need a precise rhexis, which is sometimes not possible in a white cataract, as we have seen. Now, we are using the femtosecond laser. It has created the rhexis, and now it is fragmenting the nucleus into 4 quadrants. This is the primary incision which is coming up, and following this, the paracentesis incision is made. As you can see, when you enter, the rhexis is already done for you. It's a free-floating rhexis. You don't need to bother much about that. And then you can proceed with the phacoemulsification as usual. In fact, you have a chopped nucleus for you. Now, we have also seen that the more intumescent the lens, you have a lot of milky fluid, and these lenses obviously have higher intraventricular pressure. The Argentinian flag sign is even more common in these lenses. This is another patient with a white cataract. This pattern that we are using here is a raster pattern in which the nucleus is cut into tiny cubes. Now, this is the scan of the capsule. We are just zooming in to set our settings as precisely as we can. The highest point and the lowest point of the capsule, the anterior capsule, have to be marked so that the laser fires around these points to give a good, neat, clean capsulorhexis. What we'll be seeing here now, coming up on the OCT image, is the lens. This portion, which is, you can see as the whiter portion, represents the milky fluid, and the core behind it is that of the nucleus. Okay? So now, this is the incision planning that is being done. Now you see the laser being, once the laser ready is there, you press the foot switch, just see the amount of milky fluid coming out, and this is the boom. These are the kind of lenses which give you an Argentinian flag sign. If an Argentinian flag sign is there, soft cataracts are relatively easier to handle. Let's see what this cataract actually had. Let's proceed further. Now this, once the milky fluid is out, you see it is not a soft cataract. So if you had an Argentinian flag sign, you will not possibly be really successful with phacoemulsification, and you would have a risk of nucleus drop and posterior capsular rect. As you can see, the capsulotomy is near complete. Sometimes when the milky fluid escapes, there may be some obstruction to the femtosecond laser because the opaque media does not allow the laser to penetrate. But as the femtosecond laser systems are getting faster, they are completing capsulotomy in a matter of seconds. So sometimes there is not enough time for the milky fluid to escape, and the capsulotomies are increasingly free floating. Now, once the rhexis is a good sized rhexis, that is a prerequisite to having an easier phacoemulsification, and then you can tackle the nucleus. Unfortunately, in this case, because of the excessive amount of milky fluid that came out, the fragmentation is not as good as you would see in other cases, because the rhexis is the first step. Once the rhexis is done, the milky fluid comes out, and then through the milky fluid, the nuclear fragmentation sometimes is not as good. Now, coming to fibrotic capsules again, You can use the femtosecond laser with great deal of success in fibrotic capsules. The only thing is that in certain areas where the plaque is too dense, the cut may not be complete. It's like having, you have those coupons which have a serrated edge which says tear here. So if you just put a gentle pressure, it will tear there. So that's what it is like. But you must stain the capsule. So in order to have a better visualization, you can see there's a tag here. But if you just keep the full centric petal, it will tear from the correct area and you will have a good capsulorhexis even in a fibrotic capsule. Okay, I think I'll show you the capsulorhexis. This is the capsule. See, this is the entire capsular rim which was so fibrosed. But you have a perfect capsulorhexis again in this case. Now, I think I've shown this video a lot of times, but this is the video which made us really believe in the power of the femtosecond laser. This was a 53-year-old radiologist who had a crystal lens implanted in one eye. And he wanted a crystal lens obviously in the other eye to match it because he was happy with the spectacle part independence that the crystal lens left eye had given him, in the right eye had given him. Unfortunately, he presented with phacomorphic glaucoma and he also had an astigmatism of 1.25. We in India did not have the crystal lens with the toric variant, so we not only had to give him a crystal lens and correct the astigmatism, we had to do it in a case of phacomorphic glaucoma. As you are aware, phacomorphic glaucoma again, as Argentinian black sign is more likely, and a crystal lens in fact requires a larger than normal rhexis. In a white cataract, you're normally restricting yourself to a smaller rhexis in order to make it possible. So this is the plan for this patient. You can see that this is the rhexis, the pink circle. This is the primary incision. Opposite that, we have made an arcuate incision. The primary incision is on the steep axis and the arcuate incision 180 degrees opposite will correct about 1 diopter of astigmatism. This now you will see here the kind of lens that this is. It's a rather bulky lens with a very shallow anterior chamber. Again, you can see the lens just abutting the cornea. And now now this is going to be the beginning of the capsulorhexis. And again, you will see the boom, right? This is the arcuate incision. This again will be the primary incision. Now let's see. When you take this patient in, you again stain. You may have some tags where the milky fluid interferes. This is one of our initial cases. After this, the softwood PI and the better energy and the faster laser has made rhexis even better. But as you can see here, the rhexis is perfectly central and adequately sized in order to implant a crystal lens, which will be implanted at the end of the surgery successfully. So this is a patient who came with phacomorphic glaucoma wanting a crystal lens. And we could actually say that yes, we will be able to do it. Now, in rock hard cataract, we end up using, even though the rhexis may not be as difficult, the phacoemulsification is more difficult. Getting a full through and through job is sometimes challenging and you end up using a lot more phaco power. In this case, again, we have used the femtosecond laser in this case to create 6 segments of the nucleus. In harder cataracts, we normally like to create more segments. This is again an older case. Now you also have the raster pattern wherein tiny cubes are made inside each piece, so that softens the piece even further. Now we will just be seeing a gentle hydrodissection. And now when you see the phaco being phaco probe holding the nucleus, when you see the chopper is easily able to put both the pieces apart and you see the cavitation bubbles or the air bubbles, the gas bubbles that the femtosecond laser has created escaping from behind. That basically means that you cleaved it and that's pretty much it. You get those 6 beautiful pieces that the laser had cut out for you. Of course, there is some degree of vacuum and phacoemulsification that still is required, but it is reduced by nearly 40%. And this is the post-op day 1 of this patient. There is no corneal edema. So if you are reducing phaco power, it may not be very significant in patients who have a soft cataract. But in patients with such a hard cataract, you give them results and you wow them on the day 1. one tiny issue was that the femtosecond laser requires a clear media to operate. Sometimes in a post-RK patient or in a patient with corneal opacity, we are not sure whether we will be able to focus the energy precisely and go through that opaque portion. This is a patient of RK. We just increase the energy settings of the rexus, and with that, but you can still see tags. Normally you don't see tags if there is no milky fluid. In this patient you are seeing tags because of the scars, under which sometimes the laser may not penetrate. But all in all, still by increasing the energy settings, and as you increasingly understand how the machine works in different cases, you can use it with a great degree of success in most challenging cases. Femtosecond laser is, we are just actually beginning to understand the technology, but this technology has the potential to change the way cataract surgery is done and give optimal outcomes to all patients, irrespective of how difficult the cataract and irrespective, even if they don't have access to only the very best surgeons. So femtosecond laser offers you the journey to perfection, and it's indeed a lovely ride. Thank you for your attention.